Hey all, welcome back to the Real Life Pharmacology Podcast. I'm your host, pharmacist Eric Christensen. Go check out reallifepharmacology.com. Get your free 31-page PDF on the top 200 drugs. Absolutely a no-brainer for you to get that. I highlight some of those important clinical practice pearls, as well as some of the most important things that are going to show up on board exams as well. All right, let's get into it. We've got number 181 today. First medication is finasteride. Brand name is Proscar. This is classified as a 5-alpha reductase inhibitor, and the primary use for this medication is going to be BPH. Now, it can be used for male pattern baldness as well, or hair loss. So that's another important indication that I have seen pop up occasionally as well. But primarily in the patient population I work with, going to be used for BPH. Now, how does that medication work? So finasteride ultimately reduces DHT, which is dihydrotestosterone. So by reducing those levels, that's going to help basically shrink the size of the prostate. 5-alpha reductase type 2. This is the enzyme that does the conversion from testosterone to dihydrotestosterone, which is a very potent androgen, basically. Okay, so again, DHT, it's that androgen. It promotes the enlargement of the prostate. So by utilizing a 5-alpha reductase inhibitor, we can essentially reduce DHT. In the treatment of male pattern baldness or hair loss, DHT also affects the scalp. There's receptors up there, which contributes obviously to that issue of hair loss. All right, administration, dosing, important practice pearls here. One of the most important things to know is be super, super careful in pregnancy. Absolutely contraindicated. In my practice, I've done some assisted living, some long-term care work. Caregivers even got to be careful in handling this medication. So caregivers who may be pregnant, really, really important to recognize that this medication is teratogenic. Important patient education point. This medication is typically taken once daily, and the results, the efficacy is delayed. Okay, so patient very likely is not going to take this for a week or two and see much benefit. Okay, so they'll be likely to want to discontinue it, particularly if they have adverse effects as well. But that time to shrink the prostate takes a tremendously long amount of time relative to other medications. So we're looking at months, 3 months, 6 months before we're really going to start having those benefits. Adverse drug reactions, the primary one that I see reported in the literature that I've seen in practice is impotence or sexual dysfunction. So that can definitely be a challenge there. Other things, potentially maybe a little drop in blood pressure. Again, usually generally pretty well tolerated other than the sexual adverse effects. All right, drug interactions. I want to mention anticholinergic medications. So that's your diphenhydramine, your tricyclic antidepressants, and so on. These can basically exacerbate the symptoms of BPH. So it's basically opposing what we're trying to do with a medication like finasteride. So those anticholinergic medications, they're likely to worsen urinary symptoms like urinary retention. Alpha agonists, same thing. They kind of clamp down on that pathway and make it more difficult to pass urine, exacerbate urinary retention. So any drug with alpha agonist activity. So decongestants like pseudoephedrine may worsen this. And then we've got medications like midodrine as well, which is actually used to treat patients who get too low of a blood pressure, actually. And then last, we do have St. John's wort, which I'll mention. It can reduce plasma levels of finasteride and ultimately reduce effectiveness. All right, moving on, we've got carbidopa, levodopa. brand name is Sinemet. This is a Parkinson's medication. Levodopa gets into the brain or crosses the blood-brain barrier, and then it is converted to dopamine. So if you remember, in Parkinson's, we are considered to have a shortage of dopamine. So by giving levodopa, we can increase the concentrations of brain dopamine and allow our patients to potentially move more freely and relieve the symptoms of Parkinson's disease. Now, I mentioned it's carbidopa, levodopa. So carbidopa, so there's two medications in Sinemet. Carbidopa works in the periphery, and it inhibits the breakdown of levodopa. This helps kind of reduce the potential of that breakdown, and also can reduce maybe some of the peripheral side effects as well. So again, we don't want that levodopa being broken down into dopamine in the periphery. We want that to happen in the central nervous system, where obviously the Parkinson's disease disorder is caused, or happens in the brain, I should say. Administration, dosing, we've got immediate release, controlled release formulations, and patients can be really, really touchy about their dosing of Sinemet because they know they can start to kind of have off symptoms, or where they can really have difficulty moving. It can increase their fall risk, for example. So we've got to be sensitive to that, particularly maybe if you're a caregiver giving the medication, or maybe you're prescribing or dispensing, and you're educating that patient. Very, very important to recognize when those drug concentrations are wearing off. That's likely a time where we're going to experience more Parkinson's symptoms. Now, on the flip side, if we get too high of a dose, too high of a concentrations, we're going to run into adverse effects, right? So GI, nausea, and vomiting, definitely something that can happen with the use of Sinemet. We can also have some drop in blood pressure, some dizziness associated. Rarely you may see some neuropathy, and there is a vitamin deficiency associated with this medication as well. But nausea, vomiting, some CNS adverse effects, those are going to be the primary things. And then I have to mention psychiatric effects. Definitely something you want to know for board exams, pharmacology exams. Sinemet can cause psychiatric symptoms. Now, Parkinson's disease itself can cause hallucinations and other central nervous system changes, but Sinemet can do it as well. So the higher the concentration, the more likely we're going to do this. And if you think about that, from the perspective of the medications we use to treat psychosis, we use dopamine blockers. So we've kind of got this yin and yang between Parkinson's disease and between schizophrenia. If we get too much dopamine, we can get into, psychosis and hallucinations and those type of symptoms. Too little dopamine in a patient with Parkinson's, you're going to experience some of those Parkinson's symptoms, obviously. Excessive movements, dyskinesias, that can happen at higher dosages, higher concentrations as well. Some rare things, you may get, urine changing in color potentially. Usually that's not noticeable for most patients, at least in my experience, but it has been reported in the literature there. All right, so drug interactions, let's finish up with that. I think about the adverse effect profile and that yin and yang with dopamine antagonists. So any drug with dopamine blocking activity being used on a patient in Parkinson's disease, that's going to worsen or potentially worsen their Parkinson's disease symptoms. Okay, so most common dopamine antagonists include antipsychotics, with the first generations like Albuterol generally being the worst or the strongest dopamine blocking agents. We do have some antipsychotics that are less, or they block dopamine to a lesser extent. The, I guess, least expensive one that I see used most commonly in practice there is quetiapine. It doesn't block dopamine as strongly as, let's say, risperidone, or if you want to go to the first generation agents, haloperidol. So that gets into a little bit more of the nuance and subtleties of, kind of medication selection in a patient with Parkinson's disease, but I think it relays an important point about the more you block dopamine receptors, the more you're going to cause or worsen Parkinson's symptoms and essentially blunt the effects of what we're trying to do with that Sinemet. Now, the other medication that I think you should absolutely know that isn't technically classified as an antipsychotic is metoclopramide. I've definitely seen this one come up on pharmacology and board exams for sure. So metoclopramide has some dopamine blocking activity. It can absolutely worsen Parkinson's symptoms. The other thing I do think about with Sinemet is orthostasis risk. So if you're adding other medications that may drop blood pressure, we can maybe have an additive effect there. So obviously anything used for hypertension, but also medications like PDE5 inhibitors, for example. All right, moving on, we've got Risedronate. Brand name is Actonel. This is a bisphosphonate medication, and its primary use is osteoporosis. I have seen it used for Paget's disease periodically as well. Recall that we utilize T-scores for diagnosing, navigating osteoporosis and severity. So those T-scores of less than minus 2.5, typically our patients are going to be indicated for osteoporosis therapy. If they're kind of borderline, minus 1 to minus 2.5, we may do some FRAX scoring, which is basically an additional risk factor assessment tool, basically, to assess if we should give treatment. Digging in a little bit further on the medication, bisphosphonates, like Risedronate, they inhibit osteoclasts from breaking down bone and therefore blocking bone resorption. So that's basically how it helps keep those bones stronger versus not having the medication. With administration, it's going to be super, super important with that oral administration that you follow the procedures in taking this medication. So empty stomach, 30 minutes before food, drink, or other medications. There's a lot of binding type interactions that can happen with this medication. And essentially, if we have those binding interactions, we're not going to absorb the drug and we're not going to have any effect on what we're trying to treat, what we're trying to manage. Okay? So again, empty stomach, 30 minutes before first food or other drinks, I should say, because you do want to drink a full glass of water with this medication and remain upright for 30 minutes. And the reason for that is that pill can irritate or even cause an ulcer in the esophagus, basically the lining of the throat as you swallow. And so that's why it's recommended to do a full glass of water and remain upright so that pill doesn't get stuck or sit in there, because it will irritate and it can potentially cause an ulceration on the esophagus. Important thing to think about with longer-term use, after 5 years, we generally reassess. Does this patient still need this medication? Are they at high risk for osteoporosis? Then we might extend that use. But that 5-year time period is always a good time to kind of reassess, making sure we aren't contributing to polypharmacy, but also want to make sure that we're adequately treating their disease state too. All right, adverse drug reactions. So I alluded to that, drinking a full glass of water, remaining upright, and that's because of that, GI upset, esophageal irritation. That's probably the number one adverse effect that you need to know with this medication. Other things associated, have seen some kind of muscle pain, soreness, bone pain type of adverse effects, so pay attention to that. This medication is typically dosed once weekly, but it can be dosed once daily as well. I think most probably prefer the once weekly so they don't have to take it every day. And keep in mind, even with the once daily, that procedure of remaining upright and all those sort of things that I talked about before, that remains even with the once daily formulation too. So imagine having to do that procedure kind of every day. That's definitely kind of a pain compared to having to plan it out just for a week. Other adverse effects, rare hypocalcemia, so low calcium levels. Again, this medication kind of blocks that process of bone breakdown. So ultimately, it blocks release of calcium from the bone into the bloodstream. So again, there is that potential that we could cause low calcium levels, or at least contribute to it, and that type of thing. Osteonecrosis of the jaw, I won't go into that tremendously. It's an extremely rare situation. Definitely good to talk with a dentist or oral surgeon if the patient is going to have some sort of surgery on their mouth with regarding their teeth and their jaw potentially. It would be a good idea to run that by the provider that's doing that because of this osteonecrosis of the jaw risk. Drug-drug interactions, so those binding interactions are huge. Again, before food, before other medications, make sure we administer this the correct way. Calcium, iron, aluminum, magnesium, those are particularly problematic, really, really bad. You'll basically absorb none of the drug. So really got to make sure that we're avoiding doing other food and medications with the Risedronate. GI ulcer risk, so NSAIDs, potentially anticoagulants, antiplatelets, it may increase the risk for bleeding and GI ulcers. And then aminoglycosides, I'll mention them as well. There's a small risk of nephrotoxicity, or additive risk, I should say, maybe of nephrotoxicity, as aminoglycosides are certainly notorious for nephrotoxicity on their own. All right, moving on, 184, we've got Ventolin. This is Albuterol. Also, ProAir, Proventil, you'll hear a few different brand names there. This is a beta-agonist, also called a bronchodilator as a more generalized term. And this is going to be used for acute relief of asthma attacks or potentially uncontrolled symptoms of COPD. Okay, that's where you're primarily going to see this. Occasionally, maybe in a pneumonia or other respiratory type difficulty, you may see some albuterol utilized there. Mechanistically, it's a short-acting beta-2 agonist, which ultimately relaxes and dilates bronchial smooth muscle. So it kind of opens up those airways and allows for better breathing. Now, remember beta-2 receptors, those are considered to be more so on the lung. Beta-1 tend to be more focused on the cardiac muscles. So again, the higher the dose we use, we can cause maybe some beta-1 activation. Again, not typically common in patients just using, as needed albuterol, once a day or once every other day or a couple times a week. Probably not going to cause too much of an issue with kind of like raising heart rate and the action on the heart. But it is something to be aware of there. So those adverse drug reactions, the beta-2 agonist action, beta-agonist action, it can kind of ramp you up. So again, tachycardia, you might see that pulse go up. You may see some insomnia, some anxiety, some shakiness or tremor potentially. If a patient's taking a lot of this or they get a high dose, those are going to be the big things there. Rarely, excessive use, high dosages, you may see a drop in potassium levels. It's actually potentially utilized as a treatment for hyperkalemia, so that's another important one to pay attention to there. Drug-drug interactions, I don't stress too much about drug-drug interactions and albuterol. The potassium effect, maybe. I worry about that a little bit. If you're utilizing albuterol multiple times per day, maybe they're on diuretics already. maybe they've got a borderline low or a low potassium already. Okay, maybe we should pay a little close attention to that. Tachycardia. Again, I'm probably looking at other medications that may increase that risk. Any type of stimulant type medication, for example. That's the type of thing that I'm probably looking out for with Albuterol. Again, probably not going to be common unless, patients are using, moderate to high dosages and using it frequently. If you're in the market for any pharmacist board certification study material like BCPS, NAPLEX, ambulatory care, geriatrics, BCMTMS, go check out meded101.com/store. We've got a great list of resources there. We've helped thousands of pharmacists pass their exam, and we can help you too. So go support the sponsor, meded101.com/store, and help support this podcast. All right, last but not least, we have Tramadol. Brand name is Ultram. This is considered an opioid analgesic utilized in the treatment of pain, as you could certainly expect there. Now, mechanistically, this gets a little bit interesting. It's a dual-acting opioid analgesic, so certainly binds to and agonizes the mu opioid receptors, relieving pain from a central nervous system standpoint. Again, similar to oxycodone, fentanyl, morphine, and so on. Now, it also inhibits norepinephrine and serotonin reuptake. So this is similar to venlafaxine, similar to duloxetine, and so there's potential that it can kind of work on that pain pathway as well. This is a really challenging medication. I don't love it because it's got these kind of multiple mechanisms. So we can, kind of get side effects from all over the place and have, multiple different side effects because of these varying mechanisms of action. So again, very, very important to pay attention to this medication. There's lots of clinical quirks for sure. In geriatric patients, it can increase the risk for hyponatremia. And then obviously in geriatric patients, we can also have those CNS adverse effects. So be a little careful. Older age, worse renal function, this drug may accumulate a little bit and increase the risk for some of those adverse effects. So again, kind of summing up common adverse effects. So obviously opioid type adverse effects, sedation, constipation, maybe some dizziness, for example, itching, can cause some stomach upset periodically as well. And then we've got, the serotonin risk side of it. So serotonin syndrome is a potential rare risk, particularly when we use it in combination with other medications there. One important one that I've definitely seen come up on board exams, pharmacology exams, is seizure threshold. This medication can lower seizure threshold and make it more likely that a seizure occurs. So really, really important to be aware of that. Obviously, that risk goes up as the dose increases. So in an overdose or abuse type situation where patients are taking more than they should, more than they're prescribed, this seizure risk goes up as well. Along with that, obviously, respiratory depression and opioid toxicity or opioid overdose symptoms go up as well as we take inappropriate high dosages and or, renal functions getting poor, older age. These are all, putting that patient at risk. So certainly the warnings, risk for abuse and misuse of Tramadol, it is an opioid type medication. And again, we do have that risk for increased respiratory depression at higher dosages or with other CNS depressants. All right, drug-drug interactions, wrapping up this medication. So that serotonin syndrome risk I alluded to, because of the way the medication works, important to recognize that. Respiratory CNS depression risk, other opioids, benzodiazepines, alcohol, gabapentin, older skeletal muscle relaxants like cyclobenzaprine, sleepers like Z-drugs. These are all meds that can increase that risk for CNS depression and potentially respiratory depression as well. Moving on, let's talk about CYP2D6 inhibitors. Classic example maybe being paroxetine here. So paroxetine is serotonergic, so we could have some additive effects there, but it also inhibits CYP2D6. So tramadol is actually converted to an active metabolite from CYP2D6. So this could lead to reduced efficacy, reduced concentrations of that active metabolite if we inhibit this enzyme. So again, more kind of complicated kinetics, another great reason why I'm not a huge fan of tramadol and how it can really complicate things if you have somebody that doesn't understand some of the interactions and kinetics that go along with this medication. Other drug interactions, seizure-lowering threshold medications, bupropion being kind of a classic example there. Clozapine, another example that can lower seizure threshold. So pay attention. If you've got a patient on seizure medications, let's say Keppra, phenytoin, for example, this medication, tramadol, can potentially induce a seizure. So really got to pay attention to that and make sure that we're not causing more harm than good there. And then lastly, we can have some constipation type additive effects, with our older anticholinergics, diphenhydramine, oxybutynin, and so on and so forth. All right, well, that's going to wrap up the podcast for today. Thank you so much for listening. Do me a huge favor, share me with friends, colleagues, students, any healthcare professional help us grow the audience. I greatly appreciate that. Shoot me an email if you've got any questions, comments, mededucation101@gmail.com. And of course, do me a favor, leave a rating review on iTunes or wherever you're listening. I greatly appreciate that. Go snag your free 31-page PDF at reallifepharmacology.com. Absolutely free to use. Simply an email will get you access to that. And of course, support the sponsor, meded101.com/store. All right, with that, I'm going to sign off. Thank you so much for listening. Take care, and I hope you have a great rest of your day.